Hello, everyone. Come on in. Just on time. Welcome. My name is Ryan Kronk. I'm at the Water Institute. This session is WaSH in healthcare facilities. And we've got 4 great presentations. And up first, we have Anaïs Galli from the Swiss Tropical and Public Health Institute. So please feel free to come up.
Thank you. Hello, everyone. I'm very excited to be here. Thank you for listening to me. And thank you for the introduction. So I'm here to present to you the very fresh out of our preliminary results of a cluster-randomized control trial in which we evaluate an innovative WaSH intervention for hand hygiene in conflict-affected primary healthcare settings. So a very long title, and I'll get more to the point. I'm very happy to be at a WaSH in Health conference where I don't need to explain in detail why WaSH is important, and especially why it's important in healthcare and why people need to wash their hands. So it's really to stop transmission from diseases from the patients to the healthcare workers, but also the other way around. That's why we jump right into the project where I'm doing my PhD in currently. It's a project with 10 different partners, and it's called the Hands for Health project. And the overall goal of this project is to establish a systematic approach to hand hygiene and WaSH in primary healthcare facilities and in schools for serving the most vulnerable populations. And this is a very broad aim. So let me get more into it. What do we mean by vulnerable populations? These are people that frequent these facilities that are not directly connected to a water source within the building. And at the same time, they are living in contexts where we do have conflict or very close to these hot contexts where we have a lot of internally displaced people, which then can lead to overcrowding of the schools and the healthcare facilities. We are working in 4 different countries, in Palestine, Nigeria, Mali, and Burkina Faso, whereas in Mali and Burkina Faso, we are working in primary healthcare facilities, and in Palestine and Nigeria, we are working in schools. So my PhD is on the healthcare facilities and therefore also in Mali and Burkina Faso. Also the presentation therefore focuses on this region now. The overall objective of our research is really to evaluate the effectiveness of a multi-component hand washing intervention on the hand hygiene in primary healthcare facilities in these 2 countries. So how did we do that? And also what's this intervention all about? It's an intervention package that consists of different hardware options, and I will go into detail a bit more about one specific hardware type. And then we also had a big behavior change intervention, and we also supported people with management and monitoring tools. One of them is WaSH-Fit, and I think you will hear more about WaSH-Fit in a later presentation today. So I'm leaving that open for later to not use too much time. But for the hardware, there is something special in our project because we try to test the Gravito hand washing station, which is a hand washing station that actually recycles water with gravity and without using electricity. And here is how it works. You see that there is a foot pump, which then pumps up water to the tap. And this then flows through a sand and grease trap where the big heavy particles sink. And it goes into a raw water tank where we do have a membrane module that has such small pores that it filters out bacteria and viruses. So one thing that we need to say, the soap stays in the system. So it's not a drinking water station. It's really only for hand washing to bridge the gap in the healthcare facilities. How did we test that? We did a cluster randomized control trial in 48 healthcare facilities in the 2 countries together. And our primary outcome was observed hand hygiene actions during the 5 moments of, for hand hygiene defined by the WHO. Is it okay?
Yes. Thank you.
For those who do not know these 5 moments or who are already a bit rusty, it's before we touch a patient, after touching a patient, before an aseptic or medical procedure, after the risk of body fluid exposure, and after having touched the patient environment. So in those moments, you're always supposed to use hand sanitizer or wash your hands with soap or to wear gloves, but with a hand hygiene action before that. We started off with 309 healthcare workers across these facilities, and we had a baseline data collection. And hand hygiene assessment is really hard. So we tried different methods to really assess the hand hygiene practices. So I already spoke about the observations. We had covered observations with people who usually work in these facilities under different roles. Then we had a self-reported survey about the healthcare workers' behavior, but also about different behavioral factors. And we also took handprint samples according to the method of Amy Pickering, who already spoke today, where people were asked to introduce their hand in a bag of water. And this we filtered then and looked at E. coli on contact plates. After the baseline, we randomized the facilities into an intervention group, which received the full package, and into a control group, which for now didn't receive anything. And we had a first follow-up 1 month after the behavior change intervention with the survey on the observations, and the last follow-up a year after the baseline survey, where we used again all of the methods. And now, right now in Mali and Burkina Faso, the intervention is also being implemented in our control facilities. So what did we find? As I said, it's really preliminary results. We will go much more into detail of the analysis, but I still have some interesting findings. Here's our flow diagram. You see it's very complex, and I'm not going into detail because that would be very boring. But what I want you to know is that we started in the 48 healthcare facilities with about 300 people, and the arms were quite balanced in terms of number of people. Then at follow-up 1, all over the methods, we had still all the healthcare facilities, even though one observation group could not be, we had an issue with data transmission. So we lost one facility for observations in the intervention arm. And in the last one, you already see there are only 23 facilities in both arms. If we look at all the methods, because it was really hard to get access to certain areas. And in the observation, actually, we have an additional healthcare facility that was missing in the control arm. While the staff numbers more or less the same, you also see that there was a lot of change of staff in the meantime, which is a limitation. We worked with healthcare workers in direct contact with patients. So most of them, or more than half of them, were women in both arms. And almost all of them were in the age of 25 to 49 years. And most of the people we worked with were nurses or midwife from profession. We also had very few doctors because the clinics were really, really small. So there were not many MDs. And we also had medical support personnel like community healthcare workers or interns who worked at these facilities. And in the other group, there are, for example, lab people. So when you ask people about their hand hygiene practices, you can expect that you get very positive results. You see here the baseline results. On the left are the 5 moments of hand hygiene. In gray is our control group, in orange the intervention group, and this is the proportion of people who say that they always or often perform hand hygiene during these moments. And it's already very high at baseline. It even got a bit better in the intervention group at follow-up 2, where almost everyone always washes their hands. So we could say, great, our intervention was nice, it worked. But when we look at the observed hand hygiene practices, the picture looks a bit different. These are actually box plots, but they look like bar plots because the median is at 0. And you see at the baseline, there is no difference between the groups. And by the way, this is the number of correct actions divided by the number of opportunities. We see a slight increase in hand hygiene at follow-up 1, but interestingly also in the control group. So there is no significant difference between the groups. And it all goes down again at follow-up 2 1 year later to the practices as they were in the beginning. We also looked at the E. coli. Every square represents a person, and the gray squares are the ones without E. coli, and the darker the purple, the more E. coli colonies we found on the hands. And you see that at follow-up 2, we did have a bit less people with, or more people without E. coli, but again, no difference between our groups. So what does that mean? First of all, I think you all know it, our intervention did not really have a significant impact on the intervention group, on the hand hygiene practices. But we saw a slight short-term improvement, but in both groups. So even our presence might have played a role in these healthcare facilities. I also tried to do some sub-analysis, and we actually found that, for example, soap availability and the profession might impact our results a bit. So we need to go deeper into that. And also seeing if we don't look at all the 5 moments for hand hygiene, but just 2, for example, if that changes a bit more. And finally, we really worked in insecure settings, and the security really deteriorated over the time. So it might also just be that hand hygiene is not the first thing people focus on anymore. And also our access got really hard with the time. So this really gives us an opportunity to better understand what are the WaSH-related needs and realities in these complex contexts. And are our measurements actually right for these contexts, or do we also need to adapt our measurements? Yeah, I think we still need to learn a lot more. With that, I would like to thank you for your attention. And yeah, if you have any questions, please need to ask.
So I was wondering, you looked at or were thinking about looking at the hand washing practices among patient attendants as well, because I know we work a lot in DR Congo and see a lot of people, they're like family members or other people that with them are doing a lot of like the minor care for them. And if that was something that you looked at in the settings or were thinking of looking at in the future.
Yeah, I think that would be something amazing to look at in the future. We did not look at the patient side in this project because it would have been way too big and too complicated. And because they are primary healthcare facilities, we do not have patients that stay there normally. So it would be really hard to follow up with them over a longer time. But I think it's definitely something we would also need to investigate by taking the communities into account around those healthcare facilities. That provoked many hands. Should I?
Sure, just go ahead.
I just wanted to ask you, why did you choose your study area as a conflict area?
That's a very good question. First of all, because there is almost no research in these areas. And we are working together with the ZOM, an NGO who really wanted to implement this hand washing station, but they wanted to test if it even makes sense to scale it up from a scientific point of view. So that's why we tested it there. And also this hand washing station, if you have a secure water connection to your building, you're not going to use a station that recycles water. So it's really in these contexts where until the situation calms down, we are looking to cover a gap, and then hopefully when it's better, they can install water pipes. But yeah, it's really mainly because there's a research gap and to test novel solutions for these difficult contexts.
But one more really quick question. Go ahead, Darcy.
Did you measure prevalence of alcohol-based hand rub? Is it possible that people are preferentially usually using ADHR over the machine?
Yeah, so the results you saw is the hand rub together with hand washing with soap and glove use. But yeah, we looked at it and they are using more hand rub because it's a lot more practical. But we need to get more into detail also about the availability of the hand rub, if that has an effect on the hand washing actions or hand hygiene actions.
Right, let's catch our presenters afterwards with other questions. I wish we had more time, but let's give Anaïs another quick round of applause. Up next, we've got Upama Tamang from WaterAid. Please take it away.
Good afternoon, everyone. I'm Upama Adhikari Tamang, working as Senior Advisor for Health in WaterAid. I'm happy to share my presentation in today's conference. My presentation is on sharing our experiences from the participatory approach for the life cycle costing of WaSH in healthcare facilities at the national, sub-national level. I would be sharing cases from 3 different countries, which are Ethiopia, Ghana, and Timor-Leste. Moving forward with the presentation, this is a brief outline where I would be sharing about life cycle costing analysis very briefly, and would also be sharing a background of those 3 countries and the process we went through the life cycle costing approach. I would be sharing few of the findings of life cycle costing, and would be sharing an impact of the participatory approach we had taken in those 3 countries, and ultimately the implication and conclusion. Moving forward with, we will all agree in this room that water, sanitation, hygiene, healthcare waste management, and environmental cleaning, they are very essential or fundamental to provide quality health services in health facility. It does not only provide quality and safety for healthcare facility, but also build trust among patients and visitors who come to the healthcare facility for seeking the services. Therefore, for sustaining those services, life cycle costing analysis approach is one of the key steps to be taken forward. Conducting the life cycle costing analysis, it improves planning and budgeting in order to sustain the services, and also helps the government and stakeholders to identify what costs would be required on those pillars of WaSH in healthcare that would sustain the services. And in this particular life cycle costing of process, we have looked at 5 pillars of WaSH in healthcare, which are water, sanitation, hygiene, healthcare waste management, and environmental cleaning. Very briefly, that for sustaining any services, we need to talk or think beyond the capital cost, which are other costs. There are several cost components, 6 cost components within the life cycle costing approach, some of which are the OPEX, direct costs, indirect costs, especially the government and stakeholders who needs to talk with each other and identify these costs, which are essential in order to sustain the WaSH services. WaterAid has been working in life cycle costing analysis since many years in water supply, in communities, and now gradually we're moving towards working on the sanitation aspect. Since last 5 years, WaterAid has worked in WaSH in healthcare facility life cycle analysis approach. And for today's presentation, I'll be sharing 3 different countries, and in 3 different countries, there are 6 districts and municipalities where we apply this approach. In case of Ghana, we worked in Asutifi North and Wasa East. In case of Ethiopia, we worked in Dera, Fata, and North Meta. And in Timor-Leste, we worked in Maufai municipality. And WaterAid has developed a life cycle costing analysis tool, Excel-based tool, where we enter the data, analyze the data through that tool. So in regard to the process sharing, we have categorized our presentation into 2 different phases. The first phase was completely on conducting the service level assessment. For conducting the service level assessment, what we did was we coordinated with the district level government and the municipal level government so that they are aware of what process we are taking forward. We also trained them on the M-Water, that's a mobile-based application, in order to assess the WaSH situation or the facility situation in those health facilities. We analyzed 108 healthcare facilities, we assessed those facilities, and we, together with the district and municipal government, we identified unit cost of the WaSH services we were intent to build on in healthcare facilities. So we coordinated with them for identifying those costs. And the second phase was particularly on participatory workshop, where we conducted a participatory workshop with the right stakeholders. Right stakeholders means having the municipal and the district government in place, the planning officers, and different stakeholders who are working on those district and municipality. We did some practical exercises from all the data we had collected from the assessment, and we validated the identified unit cost from the participatory process, and ultimately we analyzed the data. In case of Timor-Leste, we analyzed the current and future staff levels and time required to effectively support WaSH services. These are a few pictures. The first picture is from the M-Water training. As I mentioned earlier in my earlier slide, that this M-Water training was particularly in order to train the district WaSH focus health facility workers in order to assess the WaSH service level data. And the next one is from the workshop, participatory workshop we had on life cycle costing, where we discussed on the different cost estimation we had made. So now moving forward with the finding of the presentation, Here on the next slide, though it is densely populated, but I just wanted to clarify here that I have shared Ethiopia, Ghana, and Timor-Leste data. We have data for the different districts, and there is a total population of each district and municipality. We could see a column on cost. This column has been segregated into two different forms. One is capex, and the next is recurrent. And recurrent cost is the sum of the OPEX and CapManix. And in regard to the costs required, this is the 8 years data from 2023 to 2030. We sat with the government in order to determine the costs estimation. So that's the cost required for 8 years in order to meet the basic level WaSH facilities in the healthcare. And the next column is the average cost per healthcare facility that would be required in each district and municipality. And the next thing is per capita. If you see per capita, there is a difference among different districts in the same country within the CapManix or recurrent costs. So while deep diving on the per capita capex and recurrent costs, here I just wanted to share, in case of Ghana, we worked at WaSH East and Asutifi North, and when we see the per capita capex, the range of per capita capex within those two districts, it ranged from $1.63 to $3.24. It was similar pattern. There was a similar pattern there, 0.71 to 4.42, and similar thing was observed in Ethiopia as well. So from this slide, we wanted to share a key important message that there would be a range of data or the cost, but we need to consider the different range of data within the different district in same country, not just relying on the national estimates. So moving towards the next slide, here is one of the findings we extracted. As I mentioned earlier, that we did WaSH in healthcare facility pillars analysis, and this is average cost per pillars of all 6 district and municipality of 3 countries, where you can see the sanitation average cost per healthcare facility is the highest, followed by water, healthcare waste management, hygiene, and environmental cleaning. And in case of Timor-Leste, staff cost was the second highest. Moving towards the impact of using the participatory life cycle costing analysis, in case of Ghana and Ethiopia, we have seen that the government, district government, they have started to incorporate those derived cost estimates into the strategic and annual planning process. And in case of Timor-Leste, we already have seen some tangible impacts where they have already successfully implemented, integrated their life cycle costing analysis estimates into the annual budget, and that has resulted into increased allocated funds for WaSH in healthcare in order to upgrade those facilities by the municipal government. And while talking about the implication and conclusion, there are 5 takeaways from our end. These are our experiences that the life cycle costing approach can help the budget holders and the planning officers, especially in the district and the municipal government, in order to know what would be the budget requirement in order to sustain those services. And also, this process would help to find out what cost is required per pillars within the healthcare facilities on WaSH, so that they could prioritize and plan accordingly. And we need to recognize, as a stakeholder, that we need to recognize the range of the cost across different districts in the same country. And through this process, it has supported district government to think through what current and the potential future financing sources are. And this process also supports the evidence-based planning and programming. Thank you, everybody, for listening. For knowing more regarding WaterAid's work, there are a few websites or links has been presented. I'm sure that, it will be shared later. The slides would be shared later. Thank you so much for active listening.
If I missed that, this in your presentation, did you look at different levels of healthcare facilities within these districts? And were you able to compare if there are any differences in costs for a small primary healthcare facility versus inequalities, if I missed that?
So in case of, yeah, we did see the different level, but we didn't analyze, okay, what are the cost requirements as per those levels, but we have basically identified the public entities, which could be a primary level health facility or a district hospital, so.
Yeah, I was curious, you keep mentioning participatory life cycle costing. So does that mean you didn't measure the actual cost spent on the services, but you just came up with what people think is the cost? I didn't quite understand, and maybe we could clarify.
When we say that it's a participatory approach, that's the approach we took, that we, being WaterAid, we just didn't sit within ourselves. We talked with the district stakeholders and the governments who are the budget holders and planning officers at their respective. So we took that approach so that, yeah, they are, because they are the leaders and we are supporting them, to strengthen those services. So we took that approach, participatory approach.
Okay, but it was the actual numbers they spent on this. It was the actual cost. It wasn't just like what they thought the cost would be.
Yes, they were the actual cost that was set by the government people.
What is the challenges when we are working this life cycle cost with the government and what is it?
Yeah, there were a few challenges in case of Ethiopia. Yeah, because Ethiopia was going on different conflict situations. So there was a time that we had difficulty in order to coordinate with the district level government and to bring those data in place and have those participatory workshops. So that kind of challenge, security-wise challenges were there. But we, because our staff are there, we coordinated with time, we coordinated with them in order to gather those information. So that was one of the challenge. Yeah, other than that, there were some challenges regarding, because in life cycle costing, there are some terminologies which are not exactly in the budget line of the government. So there was some conversation around, okay, we don't have this budget. Where are these hidden? So we had to brainstorm a lot, dig into a lot. So those kind of conversation took bit time. So that was another challenge.
Okay, thank you for the nice presentation. Do they have any cost recovery mechanism in place, or we are expecting this finding can help the government to establish cost recovery mechanism so that they can recover the cost for either O&M or maintain cap money, capex and OPEX? Thank you.
So these cost estimates, they are for the 8 years, and these 8 years costs are for having the basic level healthcare facilities in place by 2030. And government do have discussed about the cost recovery. They have looked at every angle, direct cost and indirect cost. What would, what would benefit the process while moving forward? So those cost recovery components also has been discussed while we did the exercise.
All right, one last quick one.
Thanks. Probably if you can mention how the life cycle is defined, for example, for how long the new water supply is extended to serve, or the sanitation facility and the waste management, how the life cycle is defined.
So in our life cycle, as per WaterAid, what we define life cycle costing is from having those water supply or sanitation facilities in place to its operation maintenance cost, to its bigger, massive, repair and maintenance process. And there are some staff who are also dedicated particularly for the healthcare, those having those services in place. We have considered those elements into, as a life cycle costing thing.
All right, any other questions? Catch Upama afterwards. Let's give her another hand. Next, we've got Adam Drolay from PATH.
Thank you.
All right, good afternoon, everyone. My name is Adam Jolie from PATH. I am here presenting on behalf of my colleague Teddy Naddumba, who wasn't able to secure her visa. She's a health economist that's based in Uganda. This is her work. And so I am not a health economist, so there will be her email. You can email her questions. I'm here to present on her, the great work that she did. So just a bit of background and context setting here. Hospital or healthcare-acquired infections are the most frequent adverse events in health settings. There's a significant effect in terms of morbidity and mortality, as well as a financial impact on health systems. In fact, in low resource settings, low and middle income countries, we see that roughly 2 to 20 times higher, their patients have 2 to 20 times higher risk of an HAI than they do in high income countries. Of those, HAIs account for roughly a quarter of hospital-acquired or hospital-treated sepsis cases, and nearly 1 in 4 of those patients dies. In terms of a financial impact, HAI costs and treatment diagnostics account for 0.4 to 2.9% of GDP, which roughly translates to about $500 million to $1.5 billion in each of those respective countries. So significant health and financial impact. And perhaps the most shocking of all is that we know that these HAIs are preventable. In fact, there's some really good evidence that has occurred throughout the world that shows that IPC bundled approaches can reduce HAIs by anywhere from 35 up to 70% of these cases. One of the key components in IPC bundles and practices is the use of chlorine for disinfection of surfaces, equipment, and instruments. It's widely regarded and included in IPC infection prevention control guidelines for its use. However, 3 key gaps face the health system regarding chlorine, and that being availability, sometimes poor quality of the chlorine that is received, and then there's a question about its actual use. How well is IPC practices followed through in health settings? Past evidence from PATH has looked at 32 healthcare facilities across Ghana and Uganda, and we've seen that healthcare facilities, regardless of where the level is, regional referrals down to health centers, face anywhere from 1 to 2 months up to 132 days without chlorine. So that means either the facility is rationing during the times that they have, they're buying from open market sources, or they're using substandard cleaning agents such as laundry detergent to quote unquote disinfect patients. And again, that contributes to that HAI risk in the end. We have sampled chlorine solutions that healthcare facilities are receiving. And if you want to hear about that result, come tomorrow to my colleagues talk Kofi Abaram about the results from Ghana. It's shocking. So PATH is working to scale up, to introduce and scale up a novel chlorine generator. This is the Aqua Research Stream disinfectant generator. It produces a 0.5% chlorine solution, which matches the recommended concentration in IPC guidelines. There's no dilution needed, which is a huge deterrent, speaking to health staff. It produces about 5 liters an hour using common salt, water, and electricity. So part of our studies in these countries was to look at kind of the so what question. We wanted to assess the cost effectiveness of the stream compared to commercial chlorine in terms of its effectiveness on the potential risk reduction of HAIs in health systems and health facilities. The endpoints are there looking at the number of HAIs averted, reduction in HAI deaths, HAI-associated deaths that were averted, changes in HAI treatment costs, as well as looking at the estimated DALIs that were averted, all summing up into this incremental cost effectiveness ratio. A bit on our methodology, we built a statistical model that essentially took 2 different scenarios. Again, one were facilities in which they were using this on-site chlorine generator, the stream, and the second is facilities that were using and sourcing commercial chlorine received by the health system, whether it's essential medical stores in Ghana or the national medical stores in Uganda. Within those, we looked at challenges about availability. So I mentioned the issue around stockout in facilities. We looked at and did some testing and used project related data around quality of that chlorine. How does that affect the incidence rate of HAIs? And then third, around the adherence to IPC norms and guidelines. And so you can see kind of on the bottom how this data continues to be layered on to then generate our cost effectiveness. Really small font, not the point to read it, but you can see how we start with our healthcare facility, have those two scenarios, and then again begin layering on availability, quality, and the use of that chlorine for IPC practices. In terms of the inputs, we used both project data as well as peer review literature data. And so in terms of HAI infection rates, we pulled data from a recent systematic review on HAI rates within sub-Saharan Africa. In terms of efficacy in chlorine, again, a lot of that data came from either project data that we were able to test and or peer review literature. And then data on DALIs was taken from the Institute of Health Metrics and Evaluation, looking at the global burden of disease for specific HAI-related morbidity and mortality events. Regarding costing, again, lots of the sources are here in terms of where we use that. The main point here is to say that we use both primary project data as well as peer review data to inform these assumptions. And naturally, there'll be some limitations with both of those. All right, so skipping on to the results because there's just a few minutes left. The first takeaway that you can see here is that using the combined probabilities of both of those scenarios that I talked about, commercial chlorine and stream, we see across the board a substantial reduction in the number of HAIs, the HAI-related mortality rates, and DALIs across both countries. And so there are a couple things to call out here. If you look on the far right, there the data from Ghana and the data from Uganda is on the left. So the reason that there's such a difference in terms of the data from Ghana and Uganda is primarily due to the disease burden composition and demographics affected by HAIs. So what that means is in Uganda, those that are of younger age, those under 5, are significantly more affected by HAIs and thus have a longer term of life years lost, which then is reflected in the DALIs numbers. Whereas in Ghana, it's older age individuals and adults that are affected by HAIs, thus the lower rates. Looking within each country, in Ghana, we focused on general hospitals because of the types of services that they provide, those being surgical services, ICU, neonatal services, again, where the majority of HAIs, healthcare-associated infections, are found, treated, diagnosed, as well as locations where there were existing data on chlorine stockouts, again, data on poor quality of chlorine, and where we could get some data on IPC practices. Within Uganda, you can see that the effect of having on-site chlorine generation is most pronounced in the general hospital, again, because of those influences and those factors that I mentioned. Their general hospitals compared to referral hospitals have a larger budget. They receive chlorine from central medical stores, but they also have their own budget that they can go out to the market and purchase. They typically have stronger IPC practices, capacities, structures. So you see the effect is generally lower there. Whereas in general hospitals and getting down further in the health system, the chlorine stockout rate gets higher. However, the difference between general hospitals and health centers, again, is because of the nature of the types of services that are provided, the types of HAIs that are confirmed in those locations. That's the part of the reason why general hospitals are really driving this. So from a policy and practical implication, focusing on general hospitals looks to be the most effective area and where on-site chlorine generation could have an effect on HAIs. However, one of the interesting things is we begin to see the nuances up and down the health system of where chlorine either is effective, it is not effective, and where other factors such as IPC practices are being were there gaps in those. All right, the second result is, again, looking at combined HAI treatment and chlorine costs. again, those two scenarios, using on-site chlorine production and using commercial chlorine production, in nearly all the scenarios, we see a reduction in HAI treatment costs in again, almost every scenario except for health centers. And again, that's because of the nature of the services that are provided there. If you look on the left, that's the aggregate number across countries, and that's anywhere from 2.2 to 3.8 million per year. One thing that's really interesting is if you look at the chlorine cost per year here, typically the on-site chlorine is generally higher than the commercial. And that's because this is over a 1-year period. We know that these devices are expected to last much longer than a 1-year period. So if we, in the next iteration, we plan to take a much longer time view where we'd see those chlorine costs come down in terms of on-site compared to commercial chlorine. What's a health economist without a lot of numbers here? The point here is if you look in the second to the right column, the cost per DALY diverted, you begin to see the cost savings down the row. And again, not necessarily in health center 3s because of the nature of the services that they provide. There is a significant difference in the cost savings in DALYs in Ghana versus the others, and that's primarily driven by the treatment costs in Ghana, that they're much higher compared to Uganda. And again, looking at that DALYs, thinking about that age distribution and who is affected within the population is really driving that number. So we did look at what are specific determinants within the model that are driving some of that cost effectiveness. In the interest of time, I'm going to skip that. I can go find your email address if you want some more of this data. And jumping again to the final results. So there are really three key takeaways. The first is the data is beginning to show that there is a strong indication that on-site chlorine generation can positively impact or can result in a negative effect of HAI incidence rates, can lower HAI treatment costs, and can have a positive effect on DALYs. The second, the slide's a little different. The second is really around kind of implementation practice. So where within the health system are we really going to focus, and where is it kind of the biggest bang for buck? And that's really around general hospitals themselves. There are some novel approaches where we can begin to address those gaps that we're seeing in terms of health centers and that availability. And that's with production or hub and spoke type of distribution models, where they wouldn't bear necessarily the cost of the device, but they would benefit from that availability of chlorine. So again, when looking at a 5-year time period, we would expect to see even more kind of positive results over time. But the kind of key takeaways here were, again, in terms of cost effectiveness, this is looking quite positive. There were several limitations. Again, this is a narrow cost perspective that did not include some costs such as transportation, the time for productivity of on-site chlorine generation, looking at that longer time period. Again, these are things that we'll tackle in the next iteration, as well as other confounding factors such as AMR. And then again, just simple limitations regarding the robustness of peer review data, the availability of that data, and our primary data. So any questions, please email Teddy. I'm happy to entertain any kind of more program design questions. We do want to thank our partners in Ministry of Health in Uganda, the Ghana Health Service, Ministry of Health in Ethiopia for their steadfast collaboration and support. Funding is made possible by the Hilton Foundation. And with that, I'll say thank you.
How the health clinics were diagnosing HAIs? Could there be a difference just because they're not being right there?
Yeah, it's a great question. So we took the data from the last systematic review that was from this year, and to gauge that HAI incidence rate. But there's still, the farther down in the health system you go, the more challenging it is to accurately diagnose HAIs. So again, if you start to getting up into that general hospital level, you generally have more confidence because of the diagnostics and capacities that are there. There is with that a certain variability that we'd have to take into account, which clearly would affect the model.
I'm curious about the on-site disinfectant generator, and I know in the cost analysis, I'm sure your colleague put in the amount it costs to maintain and to train, and I'm not familiar with it, but is this a yearly maintenance thing? Is there a way that they can check that the concentration is high enough to actually disinfect appropriately?
Yeah, great question. So part of what was driving the on-site chlorine generator cost was we've done a total cost of ownership. So looking at the capital cost, the operating cost, the shipment, customs. In fact, some of the data that again my colleague Kofi will present tomorrow was around how often do components fail, what's the replacement cost of that, and baking that in. This was a 1-year time period, so it doesn't include a lot of those recurring costs. But we would expect to use that data to try to get a better realistic picture around those cost inputs that you were mentioning.
So, yeah, thanks for the presentation. So when we implemented a stream project in Kenya, one of the things we did was train staff on how to use stream and also how to do chlorine dilution. So was that also part of the package here? Because I feel that for the ones who use the regular chlorine in the facility, they don't have access to training, and that can also impact on the.
Yeah, the short answer is no, that cost was not included. We made an initial assumption that the cost for training and continual support was offset by the labor cost for dilution across the entire health facility because of the fact that stream chlorine doesn't have to be diluted for disinfection. Now that is an assumption, and again, it's in that next model we would want to really assess whether that is a correct assumption. But it is a limitation of the current data.
All right, let's give that another round of applause. All right, and next up we've got Darcy Anderson from UNC.
Okay, great. Thanks, everyone. I know I'm standing between you and the poster reception, so I'll try to keep it brief. Today I'm talking about WaSH Fit and examining the question of whether or not it actually improves service levels and associated health outcomes. So for those of you that are unfamiliar with WaSH Fit is a risk-based quality improvement tool that's put out by the WHO and UNICEF for WaSH and healthcare facilities. It's currently implemented in over 75 countries and is a core part of national strategies in at least 13 of those countries. It's promoted by the WHO and UNICEF as part of the Global Framework for Action to achieve the Sustainable Development Goals by 2030. And we know that it influences billions of dollars in health and WaSH sector spending across the world. So it is arguably one of, if not the most influential approaches to WaSH and healthcare facilities programming. So it warrants looking at. So to briefly walk through the process, this is all the manual for WaSH Fit, and a plethora of training materials are available online, so it's easily accessible. I'll provide a brief overview. So as a continuous quality improvement process, WaSH Fit follows 5 steps that are intended to be iterated every 6 to 12 months. So you form a healthcare facility team, then that team conducts iterative cycles of assessing the WaSH conditions, identifying and prioritizing improvements, developing an action plan and implementing the action plan, and then assessing the results, determining what to do next, and then restarting the cycle of assess, prioritize, act, evaluate, return. And the current working theory is that there's a set of inputs from political to financial, human resources, etc., that are needed to execute this cycle. The cycle has specific outcomes of improved infrastructure access, improved practices, etc. And then that results in long-term impacts associated with improved quality of care, improved health outcomes, etc. So this is the theory. on how WaSH works as proposed in the WHO and UNICEF manual, and we set out to see what evidence underpins this theory. So briefly, the WaSH assessment includes some baked-in data. So that step 2, assess the facility, generates data on service levels. This is an example. There's 96 indicators across water, sanitation, hygiene, cleaning, waste management, and then facility management overall. And it looks like this. You do a rating system of this green, yellow, red at 3 levels. And each of those 96 indicators are scored across these 3 levels. So there's some baked in service level data collection associated with WaSH already. So does WaSH work? That's the question we're here to ask today. And unfortunately, I'm here to tell you that we're not sure. So if you were hoping to get an answer to this question, I don't have it for you today, but I hope that you will leave with some lessons on how we might answer this question more effectively in the future and where we can start to make some hypotheses. So what's the state of the evidence? Well, most of the published literature, it's been around for a number of years now, 5 or 6, and it's influencing billions of dollars of spending, but most of the literature that we have available is case study reports and gray literature. Where we do have published studies, we often see more frequently that studies are applying WaSH as a monitoring tool, and they're not necessarily evaluating its effectiveness. So we see studies like, we assess WaSH conditions using WaSH indicators, here's what we found, and it's a monitoring study. The other thing we see is kind of these process style reports that say, we implemented WaSH, here's what we did. And there's no critical reflection on whether or not WaSH was actually the cause of any improvements in service level outcomes. So there's really no systematic inquiry that asks the question, does WaSH as a programmatic approach improve WaSH services and related health outcomes? So we looked at the available literature and we conducted a systematic review to try to answer this question. We had 3 objectives. The first was to describe the study designs and WaSH services that are measured across WaSH studies, to identify the inputs and activities required to implement WaSH, and then to evaluate the effect of WaSH on outputs, outcomes, and impacts. I'm not going to go through all of these today. We have a preprint of this study available online, and I'm happy to answer questions if you want to approach me after the session. And we followed a logic model framework in terms of evaluating the inputs, outputs, outcomes, and impacts. So after we conducted our search, we identified 31 studies that reported on the logic model framework of inputs, outputs, outcomes, and our impacts. 25, or about 80% of those studies, were cross-sectional or case study designs. So very little longitudinal measurement of WaSH. We found 9 studies that reported multiple rounds of WaSH and systematically compared that change in scores over time. And we found 0 studies that quantitatively measured health impacts. And I'll break this down just a little bit. So these are those WaSH assessment indicators that I talked about, that green, yellow, red with 96 indicators that are scored with that stoplight system, and the domains, water, sanitation, hygiene, etc. So the dark blue indicates studies that measured and reported that indicator. So gave any measurement of a WaSH service indicator from the WaSH assessment. Most of these are cross-sectional. So even though they're showing up in dark blue, usually that's a one-time measurement at the end of WaSH implementation. We see these lighter 2 blue categories are something was reported, but there was something in the data that prevents us from concretely determining what indicators were measured, at what time point, was it before implementation, was it after implementation, or the indicators were measured, but they were never reported in the literature. So you'll notice here the overall trend is fairly spotty. Even though WaSH is generating the service level data by default through the WaSH indicators, we're not seeing a lot of it reported in the literature, And that's a big limitation to understanding whether or not WaSH works. The other thing we see, this is what we found when we looked at measures of outputs, outcomes, and impacts. Again, the dark blue is something that was quantitatively reported, typically cross-sectional. The yellow stars here indicate something that was a longitudinal measurement. So there was a before and an after, or a midline and an end line. The light blue is something that was qualitatively reported. So there was some statement on, we saw improvement in healthcare acquired infections or something similar, but that didn't have a specific quantitative indicator associated with it. And the gray, not reported at all. So what we can see here is, generally speaking, there's some type of narrative description of the inputs required to deliver WaSH, but very little quantification of those inputs. We do better in terms of measuring service outputs. And again, these are primarily these WaSH fit indicators. So that WaSH fit assessment that's baked in, typically those are reported. Typically those are reported cross-sectionally, but we have a small number of studies that are reporting some sort of change over time. We have fewer outcomes reported and no health impacts reported at all. When we look at the types of outcomes that are reported, typically they are in these broad categories. So we see outcomes related to policy changes, for example, adding WaSH fit to national minimal essential health service packages. We see qualitative findings around coordination and collaboration improving, specific outcomes related to funding, changes in knowledge, attitudes, and practices among staff members, but as well as among communities. And then we see outcomes related to community engagement. Not a lot of health outcomes here, you'll notice. So most of these are kind of process level indicators, often related to policy, budgeting, etc. So what did we conclude? Well, WaSH may improve service levels. We did find 9 studies that reported a longitudinal data demonstrating improvements from baseline to end line. So where studies are reporting this longitudinal data, typically it does indicate some sort of positive change associated with WaSH fit. But I will highlight that we had no studies that compared WaSH fit against a reliable control. So it's impossible for us to know. Many of these studies were done during the time of COVID, where often there were improvements we know in distribution of soap or emphasis on hand hygiene training. So it's hard to say whether or not WaSH fit was driving this change or whether or not this change was the general trend and we would have seen this anyway. We concluded that there was insufficient evidence to assess if WaSH fit improves health. If you recall that column of health impacts, which was gray, not reported for any study, it's just not out there in the literature. We found 18 studies that qualitatively reported some sort of cross-sectional outcome, typically related to policies or budgets, but we're seeing no rigorous measurement of health impacts. And we're seeing, again, no studies that are being compared against a control. Interestingly, we did see favorable perceptions of impact and recommendations to scale. So across these 31 studies that are evaluating WaSH fit, we see typically some sort of qualitative or cross-sectional report on WaSH fit, and then you get to the discussion and conclusion section, and it says, WaSH fit works great, we recommend to scale it up. So there's this mismatch between the actual rigorous evidence underpinning WaSH fit and the recommendations to scale it up and its popularity that we see across the sector. We have an additional study to present on this tomorrow. So if you're interested a bit more on the WaSH fit process and why we might be seeing some of these favorable perceptions of impact and recommendations to scale, despite the lack of evidence, come back on Tuesday and we'll present more of that tomorrow. So where do we go from here? What are the actual next steps for improving evidence, given what we found so far? Well, the first is to disaggregate and report the results of WaSH fit assessments. We already generate this data. These are the WaSH fit assessments that are baked into the WaSH fit tool. And so it's fairly low-hanging fruit to take the assessment data that's already been generated and simply report it. And then we can start to look at change over time in WaSH fit indicators as it's being rolled out. The second is to develop a robust theory of change. That diagram of inputs, the WaSH fit cycle, and then the hypothesized outputs. To date, all of that is theoretical, and I will again plug my session for tomorrow. We'll talk a little bit more about this theory of change and how it may or may not work for WaSH fit. And the next one is to conduct experimental studies and exploit natural experiments. And I recognize that I'm a researcher up here plugging additional research, but I will say that much of this is more achievable than we think. WaSH fit generates a lot of natural data. We're collecting all of these records on process, all of these baked in assessments on WaSH fit service level indicators. And there are opportunities to combine this with data that already exists. Many countries have health information management systems that already track relevant indicators, for example, healthcare acquired infections. We may look at facility revenue, for example. We may look at patient volumes as a proxy measure for care seeking and service satisfaction. And if we combine these two data sources, we can start to get at this question of does WaSH fit work in a fairly cost-effective way. So I'm not up here advocating randomized trials, although that would be lovely if someone wants to do them. But my key takeaway is that WaSH fit evaluation is critical and it's achievable. So if you're running a WaSH fit program, feel free to come up and chat to me afterwards if you'd be interested in exploring some of these things further. And so I'll leave it there with the summary. You take away these 4 things. We know WaSH fit is very popular. There's a widespread belief that it works, but there's very little empirical data. And impact evaluations are possible to add to routine monitoring and evaluation without much extra effort. And before we promote scale up, we really should step back and determine if, how, and why WaSH fit works. If you'd like to see additional information on this work, this QR code will take you to the preprint for this study and to recognize my UNC collaborators here. And this is my contact information. Feel free to follow up with me.
Thank you very much for presenting this. And of course, in the sector, there is a misconception that, in healthcare settings, WaSH fit is the silver bullet, is the solution for everything, right? I'm glad that it's coming from your end. My question to you, after hearing all of your presentation, my question is: this is the best tool to assess the service level status and inform your future intervention, not necessarily the tools that will help you to actually develop a plan, then subsequently guide you how to implement and get the results. So it's all about assessment and having a robust evidence base to inform your programming so that you make a right decision. So isn't it the next word forward will be also redefining the WaSH fit definition so that the misconceptions we can actually give away from the people. It's not only having the data, these colleagues, make sure that how we use your data for future program and redesign and revitalizing is quite key. Just wanted to flag that to you so that at least people like us, we actually use these on the ground. Colleagues who suggest this to the countries and to the government is not necessarily necessary. Thank you.
Absolutely. I should have you come co-present my session tomorrow because we'll be getting into a number of those issues. Yeah, it's a great point. Thinking about WaSH fit, it is one of the best and most comprehensive service level assessment tools in the sector today. So it has a tremendous number of strengths, but is, I would argue, exactly your point, frequently misrepresented in terms of what it can and cannot achieve.
All right.
Yeah, Victoria.
I'm curious your thoughts. I mean, I know we showed that none of the studies are showing health impacts, but I feel like there's also been a lot of discussions about, do we need to show health impacts when we know that like establishment of services is a goal in its own right, and we already have a good evidence base of least health impacts. So do we need to add the response? Does it feel like that's necessary, or do you think that just identifying like that longitudinal over time, are we actually improving WaSH services? I don't know.
Yeah, that's a fair point. And I do think there's something to be said for, do we really need to, for example, replicate WaSH benefits in healthcare facilities? And spend billions of dollars to find out that we didn't change healthcare applied infections at all. I would say we don't really have robust evidence of those interim outcomes of changes in service levels. So start there for sure as a much easier and cheaper entry point in terms of monitoring and evaluation. I do think there is some benefit in terms of measuring impact, particularly as we think about cost effectiveness of different WaSH interventions within a healthcare facility. So I would suspect, for example, that we might see a greater cost benefit from water than we might see from sanitation, for example. But I'm speculating there. I don't know if that's true, but if we had that type of data, we could start to prioritize and plan interventions in a way that would achieve the greatest impact, recognizing that we're not going to immediately reach basic service everywhere all at once.
All right, shameless, well, let's talk afterwards. Question. I don't want to keep everybody from the happy hour. Shameless plug, if you want to keep talking about Washington HCF research, we have a side event on Thursday morning, so come join us. I think our speakers will be up here if you want to come follow up with more questions. Let's give them all one more round of applause.
Cool. Yeah, I've always been figuring out ways
There's a very good study.
Yeah, I did too.
I like
We did like two.
Yeah, yeah, it was.
Because that's what the interesting stuff I'm doing. People are using it for.
See you again.
Last question. Your study
the system is designed to save. That is the kind of several rounds. To make it easy as possible. The challenge is that there's an area where two people won't have enough time to. We have a trouble. It takes time.
Like there's more there.
Sometimes.
Every country I go to, there's new stuff.
I think what we try to do is to solve the whole in the initial training. There's 5 assessments. During like these are some hard divisions that I didn't know. Oh, really just I'm all training on it's
Just we're involved.
Yeah.
You're done tomorrow.
I'm part of a side event on Wednesday.
I brought it.